Karen Hoare from Massey University.
Thank you very much, Bruce. Can you all put your microphones on mute, please, so that we don't get any background noise. So, as Bruce said, this is part 2 of a talk from part 1 was taped and is on YouTube from last week. And I wanted to pick up on a couple of questions that seemed to be pertinent to the medical students last week. And that was around the managing feverish illness, detecting serious illness, and also febrile convulsions. So the first few slides will be around that topic. And then we're going to go into cases. And what I will ask you to do is to assess what you think the picture may represent, which infectious disease the picture may represent in the case, and send it in a chat. And Bruce will look at the comments in the chat to see how many of you are getting it right. Okay, so with no further ado.
And it will be anonymous too. We won't say who said what.
No, unless we want to give them a virtual fish, chocolate fish. So this is the scale of the problem. Parents have great concerns about fever. And I discussed briefly last week this whole concept of fever phobia, and I've put the reference to that journal article that I talked about last week. So just a reminder that it's normal for toddlers to have 8 to 10 infections per year, often accompanied with fever. So when parent comes to you with terribly worried that their little one has got a fever, it's normal. And if they didn't get fevers, they wouldn't be getting an immune system. So the myths perpetuate, and this idea of fever phobia perpetuates. And it's our responsibility as healthcare practitioners to dispel that myth and to teach parents what the signs of serious illness are. So how do we measure This is taken from the NICE guidance, how we measure temperatures. We measure not with a mercury thermometer. So if you've got any grannies around and they've still got mercury thermometers, very environmentally unfriendly, and we shouldn't be using them. Dangerous too. So the NICE guidance suggests that the tympanic thermometer is the best way, or the axillary electronic thermometer under the arm. And for babies less than 4 weeks old, the NICE guidance is axillary. Just a reminder how we detect serious illness. Use the 3-minute toolkit, another plug for the Spotting the Sick Child website. So A, B, C, and then disability, and then D, E, F, G, don't ever forget glucose. Take parental reports of fever seriously. If parents are concerned that their child's unwell, take it seriously. The NICE guidance, it's a key factor in the NICE guidance that parents know their children, and if they're concerned, there is a reason for that. Use the electronic thermometer in less than 4 weeks, and use electronic chemical dot. Chemical dot isn't advised for healthcare practitioners. They're not that accurate. These are the chemical dot ones that parents can buy from the pharmacy. An infrared tympanic thermometer is the best way to take a temperature between 4 weeks to 5 years. Always measure and record TPR and capillary refill time. Assess for signs of dehydration, and they are prolonged capillary refill time, weak pulse, abnormal skin turgor, increased respiratory pattern or abnormal respiratory pattern, and cool extremities. And just a reminder that this is the real concern, tachycardia, not high fevers. So always very important to take an accurate pulse rate or apex beat. This is taken from the NICE guidance, and you've got the clinical guideline there. It was first published in 2007, and it was updated in November last year. the NICE clinical guideline uses the traffic light system. And the traffic light system, the traffic light system is a tool for prioritizing serious illness and children with fever. And it assesses certain symptoms. Depending on the potential seriousness of the presenting features, clinicians can then make an informed decision on the most appropriate course of action. So features associated with fever in children have been categorized into 3 groups. There's the green low risk, amber intermediate risk, and red high risk. And these help professionals identify the risk of serious illness. Children with symptoms that fall into the greens category of the traffic light system and have none of the features of the amber and red can be safely managed with anticipatory guidance to the parents. So this is the amber, sorry, somebody's got their computer audio on. Could you put your audio on mute, please? It's quite disconcerting when you're trying to talk. So
it
the
should all be off now, Karen. I've just checked. So.
Oh, cool.
Yep.
So, for example, if you were assessing a child by telephone, which is what we're having to do now, you would ask about these features, particularly the respiratory rate. You could ask the parents to count the respiratory rate, talk about the feeding, and ask about anything else, the other section. So if they've had fever for more than 5 days, you would start to be concerned about Kawasaki's disease, a swelling of a limb or a joint, septic arthritis, non-weight bearing, not using an extremity, could be septic arthritis, leukemia, all manner of differential diagnoses, and a new lump more than 2 centimeters. So you would be wanting to see that child again, but not needing to send them directly to hospital. So details of how we do safety netting, or how I do safety netting, will be given at the end later on in this presentation. So any of these signs, and the child needs to be admitted to hospital, or certainly be seen by a pediatrician urgently. Temperatures are not a concern except in babies less than 3 months old. So between 0 to 3 months, a temperature of more than 38, the baby needs to be sent for review by a pediatrician. 15% of babies with a temperature above 38 degrees have serious infection, sepsis. So I thought I would share our pictorial aid memoir that our receptionists use at Greenstone Family Clinic. So rather than lots of words that the traffic light system has, I devised this simplistic picture and associated traffic light colours. So
Karen, could I just ask a question?
Yes.
The real tough one is the orange. I mean, the red, hopefully none of us are going to miss, are we?
No.
And I guess just some strategies. I wonder, sometimes it's very hard to check a child's pulse, and I wonder what you thought about seeing where you'd get with a pulse oximeter on their finger as getting the pulse as one way.
Yeah, I always prefer, sorry.
Yeah, yep.
I always prefer to do an apex beat, Bruce.
Okay, so that's a good one, yeah.
And
I guess
I always teach the medical students that that's the best way to take a baby's pulse, really, in a less than 5-year-old.
Yeah, I guess the other issue is if you're concerned, because sometimes you're not, you're in this grey zone, aren't you?
You are.
Talk to the hospital, and that's sharing the risk
Exactly, yeah.
Getting the monkey, and it gets, as I say to everybody, it gets the monkey off your back. You've shared the monkey with somebody else. So you can go home and feel like you've done the best. And I have to say the pediatricians are excellent. They're very willing to see people because they're not looking at the kid. They know you're looking at the kid, they're not. Although I guess you could by video today. But they'll often give you quite good advice because it's nice to keep kids out of hospital if you can. And sometimes I remember having one so relieved, she said, we'll give the child a bit of amoxicillin. If he doesn't get better, send him in. And that was absolutely perfect. This kid was sort of, right up on the cusp. So they're the hard ones.
They are. You're absolutely right. And I would completely support what you said about the pediatricians. Being married to a pediatrician, he often says to me, just ring a friend, just like you say, get the monkey off your shoulder and talk to the pediatrician, ask them what they would do, ask them what further tests you should do. And you're right, pediatricians are generally lovely people. I gave a plug to the medical students last week to become medical students, to become pediatricians, remember? I just want to illustrate why this aid memoir for the receptionists, who we call the silent clinicians, is so important, because they're the front line for primary healthcare. And we had 2 babies over the course of, I think it was 2 years, we had 2 babies that actually died because the parents of one particular pair, I remember vividly, was teenage parents who in the winter had brought their baby into the practice all covered up in blankets. It was winter, in the pram, shy, quiet, sat down, waited. And when the GP looked at the baby, it was moribund, and the parents had thought that it was sleeping quietly. It was a very, very sick baby, and sadly it died. And what we realized was that we weren't being the best clinicians in terms of that anticipatory guidance. As soon as somebody comes into the reception, if the receptionists are busy and you've got shy people in the waiting room, or people who don't speak English as their first language, it's quite difficult to go and interrupt the receptionists and say, my child's really sick. So what we've taught our receptionists to do is to use this aid memoir and show the parent. It's a laminated sheet. Show the parent, say, how worried are you about your baby? And if they point to an orange or a red, the receptionists come and get a clinician immediately. And I know at least 5 times this has been used by one of our particular receptionists, who very definitely probably saved a life once because the child was really sick and needed to go straight to hospital. Cornerstone commended us on this process. And Cornerstone is the quality assurance, national quality assurance for general practice, although I think it's changed to something else now, isn't it, Bruce?
It's going to be modified, yeah.
Oh, have we frozen? Oh, no, okay, sorry. So Bruce was asking about management. So this is, and about how we, what we tell parents. So the febrile seizures URL in the right-hand corner, excellent BMJ clinical review of febrile seizures. This was one of the comments from last week's, one of the questions from last week's was, do antipyretics prevent the febrile seizures? No, they don't prevent febrile seizures. And then the patient.co.uk, the reference to the patient.co.uk website in the corner is an excellent resource for parents around febrile seizures. So there's increasing evidence that genetic factors contribute to febrile seizures, and the background prevalence of 1 in 30 rises, so 1 in 30 children rises to 1 in 5 if a sibling has had a febrile seizure. And if a parent's had a febrile seizure, it rises to 1 in 3. So it was previously thought, and I suggested last week, that the rapid onset of a temperature contributed to febrile seizures. That is incorrect. They have disproved that. Prophylactic antipyretics do not reduce the risk of recurrence if a child's already had a febrile seizure. It's thought that the fever increases brain temperature by the release of inflammatory mediators such as the cytokines. In one study, children with higher temperatures compared to febrile controls were more at risk of having febrile seizures. But beware an alternate diagnosis if the fever is less than 38. So clusters of afebrile seizures have been seen in gastroenteritis, particularly rotavirus infection. Risk factors for febrile seizures are age of onset, 18 months. A family history, as stated, a relatively low grade fever of less than 39, shorter duration of the fever before the convulsion, and multiple seizures during the same illness, and day nursery attendance, interestingly. Don't prescribe antibiotics for fever without a diagnosis. That can be quite dangerous because you could mask a bacterial meningitis or a sepsis. And rehydrate. This is anecdotally, I guess, but also obviously one of the key factors with children. They stop drinking. Anecdotally, we've had children or little ones come into the practice looking really sick, very miserable. We've given them Pamol 4 misery and we've rehydrated them, and then within an hour they're bouncing around the waiting room. So children get sick very quickly, but they also get well very quickly. And then, very important, remember the safety advice around paracetamol particularly. The fever phobia article suggests that parents do more damage trying to give regular paracetamol or more than the recommended dosage of paracetamol in an attempt to reduce a very innocuous fever. So every 4 to 6 hours paracetamol, give the correct dose, and keep the paracetamol in a cupboard, in a locked cupboard away from the child, because children can get the tops off bottles of paracetamol. And safety nets. So provide verbal or written information on signs of serious illness. If it's a green baby or a child, you don't need to see them again, but if it's an amber one, you do need to review whether that's by telephone or by seeing them again, or by speaking to a paediatrician or arranging access to another centre for review, such as an A&M after hours. And then this is the slide from last week, teach the signs of serious illness. So I guess the 2 signs that I always teach, or emphatically, is the non-blanching rash. So this is the glass test, which is common in the UK, but stretching the skin does the same thing. You're looking for a rash that goes away. So that's a blanching rash. You don't want to see one of these non-blanching rashes. Because that's a sign, obviously, septicemia. And nasal flaring, grunting, chest indrawing, increased work of breathing, all signs of pneumonia, and skin turgor dehydration. So in summary, don't forget that wonderful Spotting the Sick Child 3-minute toolkit assessment, and it includes eyeballing, so general impression of the baby child, and then A, B, C, D, TPR, temperature, pulse, respiration, capillary refill time, and don't ever forget glucose. Don't treat fever with antibiotics unless there is a diagnosis, unless you've spoken to the paediatrician, as Bruce has suggested earlier. Antipyretics are good for misery, but they don't prevent febrile convulsions, and take parental reports of fever seriously and give anticipatory guidance. Okay, so this is topic 4 from last week, cases. So Bruce, I'm going to show some pictures and give a little bit of a history, and then I want the participants to, in the chat function, just suggest what the diagnosis might be and what the diagnostic test, or if there isn't a diagnostic test, what the clinical assessment would be. Okay, I'll give them a bit of time to have a think. Case 1, so a 15-month-old. This is the rash. The parent says it's the first time they've ever seen anything like it. There's glands in the neck. They can't eat or drink because the mouth is so painful. What do you think it is? Anybody having a guess yet? Bruce?
If they can write in the chat box.
Yeah.
We've got foot and mouth disease, somebody?
Yeah, right.
Measles?
Right.
Any other suggestions?
Any other suggestions? Come on, be brave.
On the table. Rubella?
This is anonymous.
Anonymous. Chicken pox?
Oh, getting warmer. Not
Money
warm
on the
enough
table.
though.
Vertigo? Remember,
No,
it's in
getting. All right, I'll. Here we go. So
okay,
describe the lesions. So let's describe those lesions.
Okay, and we've got Jane here. It's either hand, foot, or mouth, or could be herpes stomatitis if the gums are involved.
Yeah, that's, well, she's a nurse practitioner and she's one of my
one
of my teachers with me, so she would know. Well done, Jane. So if we describe it, there's vesicles on the lips, the tongue, the palate, the gums, and the buccal mucosa. She's absolutely right. It's herpetic gingivostomatitis, so herpes simplex virus type 1. Person-to-person spread. Incubation period 2 to 14 days. It's infective till lesions are crusted, and unfortunately it's very supportive. Babies do have to go into hospital with this because they can't drink. If you catch it early, you can give acyclovir or valcyclovir, but only if it's within the first 48 hours of the first tiny little vesicles presenting. Okay, very unwell 1-year-old. Capillary refill time of 7 seconds. If you were in primary care, we wouldn't be doing a blood pressure. Blood pressures are a very late sign of, low blood pressure is a very late sign of sepsis in infants. Very drowsy, febrile, but appears cold, and this is the appearance. Right, guess. What test would we be doing on this?
Okay, write them out, folks. Money on the table, please. Commit yourself. We've got LP, what mean?
Lumbar puncture.
Oh yeah, meningococcal lumbar puncture, meningitis.
Oh, well done, well done.
Glass test. Is the blanching or non-blanching? Yes.
Yes, this is the non-blanching rash.
Yeah.
And this child is very sick. Remember last week I told you about the little boy that I sent into hospital within half an hour of the first little spots appearing. He was completely covered in this rash. That child's had a lumbar puncture. Look, you can see the plaster on his back. So describe widespread petechial purpuric rash, shocked, Glasgow coma score. Meningococcal disease, diagnosis through blood cultures. But as we said last week, in primary care, we would certainly start give an injection of antibiotics immediately. We saw something like that and send them to hospital with all the bells and whistles. Never send purpuric rashes to hospital in the parent's car. You always send them in an ambulance. So nasopharyngeal carriage in up to 20% of people. Don't know why some infants contract this. incubation period 2 to 10 days.
So Jane says no lumbar puncture. That's because you'd want the lumbar puncture done in the hospital, I
Yeah,
presume.
exactly. Well, we don't do them in primary care anyway.
The other thing would be, as Karen says, bells and whistle in terms of the ambulance. It must come now. You want the cardiac arrest type ambulance coming. The reason for an ambulance is it has a radio, so if it gets a flat tire, it can phone another one. You get a family, car breaks down, has a car crash, they're going to be fluffing around with insurance and blaming people. And you want this kid in hospital, and phone the hospital so they know there's a very sick kid coming and they'll be waiting at the door for this kiddie if you describe them. And that question we talked about last week, I mean, IV antibiotics if you can, IM if all else fails, because these kids are going to be pretty shut down.
Thank you. Absolutely. I'd forgotten. Jane King probably knows which antibiotic. Oh no, maybe not. Which antibiotic is it? Because we've changed from benzyl penicillin in primary care. I was going to look that one up to tell you this week. Anyway.
Ceftriaxone, somebody said.
Yeah, I think it is ceftriaxone now, isn't it?
I don't know whether we keep ceftriaxone in hospital, whether we keep that. In fact, as I said, anything you've got, basically. And you'll have ceftriaxone.
We'll find the Ministry of Health advice for primary care, because this talk is for primary care primarily.
Just making the comment about needing to resuscitate them before giving antibiotics. So I don't know, what do you think of that?
Well, if we were in primary care, we'd be giving the antibiotics. Yeah, absolutely. If we could get a line in, but we'd be very definitely wanting them to the into the ambulance and off to hospital. We have discussed having intraosseous access in primary care, but very few practices would have that, I suspect. Certainly general practice, and it's best to just get them to hospital. Okay, case 3, an 18-month-old, screaming, hot, very upset child. Mother can't see him, no rash to see, seems in pain, no obvious external source of sepsis. And you look in his ear and you see this. I bet everybody's going to get this, hopefully. Have we got some? Oh yes, we've got some. Flashing. Yeah, perfect. AOM. Yeah. So the treatment of acute otitis media, antibiotics or not. So I've found the Cochrane systematic review, antibiotics for acute otitis media in children. The reference is there. There is no reduction in early pain with antibiotics. There's some reduction in pain at 2 to 3 days. Now, if you think of a tiny child, little child, less than 2 years, you do want to reduce the pain, which is why you would consider giving antibiotics for acute otitis media in bilateral in a less than 2-year-old with a discharging ear, or a discharging ear on separate to a 2-year-old is another reason for maybe giving antibiotics. But
that's an acute discharging ear, I think, Karen. They don't make that distinction. A chronic charging ear is a different.
Yes, it is.
So the acute discharging ear is the abscess and the drum's built up and it's just burst. And then, but just remember, antibiotics don't make people get better quicker. It only controls pain.
Yeah.
And the BPAC guidelines are a little bit more cautious than the health pathways. The health pathways say, I think, give antibiotics to everybody under 2 years. Most people agree to give it under 6 months. And I think the BPAC guidelines, this is a situation, I think, bilateral otitis media, yes, kid looking sick.
Yeah.
The other thing is, I also err on the side of caution with Maori and Pacific kids because
Yeah.
of the issue of mastoiditis. A Pākehā kid come in with a unilateral otitis media, I usually negotiate that with parents.
Yeah.
But
Totally agree.
yep.
And
Good.
don't forget, you can do harm. 1 in 14 children who have antibiotics will get some kind of adverse reaction, such as, or not, it's just a side effect. It's not an adverse reaction. It's a side effect such as diarrhea. So, and you don't want to give more problems to a miserable infant. And then we used to talk about the delayed prescription technique. I don't know what you think about that. I'm not that keen because you're trying to make the parent a clinician then. I would rather see them again.
I agree. I think just saying either yes or no to antibiotics,
yeah.
and if no, then we need to reassess if you're worried about this child getting worse. But you're usually seeing the child on the worst day of the illness when they're brought in, and they get better after that. And the other issue is whether between 5 and 10 days of antibiotics. There was a trial in the New England Journal of Medicine where they gave Augmentin, which was an awful drug to give, and between the 5 and 10 days, 30% of the kids got diarrhea and nappy rash.
Yeah.
So,
yeah.
5 days is usually enough.
Antibiotics aren't innocuous in infants, are they, that don't need them? I mean, they're absolutely essential if you do need them. What I would emphasize is the supportive care of infants. So paracetamol, it's painful to have AOM. Regular paracetamol, not just when the child starts screaming. So every 4 to 6 hours for at least 48 hours. And fluids, and yeah, all the supportive cares of warm wheat packs on the ears, etc. 18-month-old screaming hot, very upset, mother can't settle him at all, no rash to see, all of those other points from the history. Before a chance to give any treatment, child suddenly improves. Why? Because the eardrums burst. Right, so in the old, Bruce has just alluded to mastoiditis in the old pre-antibiotic days, up to 20%. I can't see that because of the patients with otitis media developed intracranial or intertemporal complications. Don't forget mastoiditis when you are looking at ears, because it can be serious, very serious. Situation's different now. I think I've seen about 2 or 3 mastoiditis. What about you, Bruce?
Sorry, just say it again. I'm just reading.
I've only seen about 2 or 3 mastoiditis.
Very rare. I only ever saw one when I was in hospital. I haven't seen. I've had one in primary care, but that was in a man who had a cochlear implant, and they are more likely. Jane was right. It is ceftriaxone, which is the drug you'll have for gonorrhea in the practice. And there's a question here about antibiotics don't resist the otitis media with effusion. Somebody suggested that doesn't make any difference to outcomes whether you give antibiotics or not. You still get the same rates. The only difference it makes is obviously getting very sick, like mastoiditis, and the pain. So it doesn't.
Yeah. I mean, that was the main feature in the Cochrane review, that it just did reduce pain 2 to 3 days, not immediately, but in 2 to 3 days. Okay. Right. Sorry, have you got this bar that keeps coming in my view? Case 4, something going around the school. Not unwell, looks awful, mum won't take him out, seems to be spreading on face. Now sister has it too. Oh good, we've got some people suggesting what it is. I think there's a classic feature there that we know. What's the...
Yep, impetigo, somebody says impetigo.
Yes, staph impetigo, we've got the golden cross. Now sister has it also. And yeah, we see them like that, don't we, in primary care. So lesions around nose and mouth with golden crusts, impetigo. probably staphylococcal. We do not do cultures for this. We don't do swabs for this. Very infectious. The child needs to be kept off school or daycare until all the crusts have gone. Hygiene. So if it's not very extensive, we generally do give them antibiotics, and we generally give them cefalexin rather than flucloxacillin, because little ones hate the taste of flucloxacillin, and of course erythromycin in penicillin allergy.
Okay. Just a question here, and just going to make a comment. If you're going to give Fluclox, and as Karen says, kids don't like it, you can give it with food, but you have to sort of double the dose you were going to give. You can give Fluclox, in adults it's Fluclox 1,000 milligrams TDS with food. And I tell my doctors in training, nurses and practitioners in training, when I mentioned that to a group of GPs 2 years ago, they cheered, because trying to get people an antibiotic 4 times the anti-stomach is impossible, because the only time you remember to take it is when you put food in your mouth. There's a question there about perhaps doing a swab if you've had recurrence. I think recurrence is a different situation. Yeah. You might be getting a bit of staph resistance. You will also grow strep. So even if you grow a strep on a swab, you'd still give a drug that would get staph. So you still give if you only have penicillin and you're on the Chatham Islands, you just give penicillin and hope.
Hope for the best.
We don't use topical antibiotics either.
No, we don't.
We use hydrogen peroxide for small.
We do. Yeah, we use Cristoderm. I need to take that query topical off there, because certainly we look at patterns of resistance in our geographical areas, and we've got terrible antibiotic resistance. Yeah,
and the more you give it, the more the resistance goes up. Yeah. A good point in education, we sent a gem out saying stop using topical antibiotics, and there was a national drop in the antibiotic use, so we felt very pleased about that.
Yeah.
Pathway says cefalexin.
Yes, that's right. Cefalexin. That's what we generally give rather than flucloxacillin, because the little ones won't. The fluid flucloxacillin is disgusting. Yeah. Okay, so this is. Have we got some ideas what this might be?
What have we got here? The pictures give it away, guys.
They do really, don't they? Okay, describe.
Foot and mouth, yep, we've got them all. Good.
Vesicles in different sites in the hand, the feet, and the mouth. It's caused by the Coxsackie virus, hand, foot, and mouth disease.
And discovered in New Zealand, apparently, this thing, Coxsackie. Somebody always been attributed. It's we're the first onto Mount Everest and the first onto hand, foot, and mouth disease, and perhaps the first to eliminate the COVID-19.
COVID-19, I know, that would be fantastic, wouldn't it?
Yeah, we can all go out.
So close contacts, incubation period 4 to 6 days. It's one of those conditions that takes day nurseries, kindergartens by storm, and it's self-limiting really. Parents come with it very concerned, but there's not a lot you can do for it.
Can you get it a second time?
Pass. I don't know.
My granddaughter got banned from daycare, which was rather odd because that's where she got it from anyway. The daycare centers are a bit counterintuitive. That's where you get the viruses. When you get them, they won't let you back in there, but there's clearly lots of it there.
I'll find that out.
I don't think it's known, actually.
No.
Unless somebody in the audience has great knowledge. Let's ask the greater audience.
Yeah, Jane, will you look it up? Right, illness going around the nursery, fever, another very common one, generally unwell, headache. 7 days later, develops a rash on the face, progresses to a lace-like rash on trunk and limbs, aching in the joints. Oh, we've got quite a few people
Yep.
Hazarding guesses here.
Slap cheek.
Well done. Yes.
Cheek,
Who knows what?
bully.
Yes. Hannah knows. Well done, Hannah. Oh, sorry. We were supposed to be anonymous. Okay, come on. It's freeze.
Yep. No, we've got parvovirus, slap cheek.
Yes, that's it.
Morbili.
Bright red cheeks.
Morbili.
Pardon?
What does morbili mean?
Morbilliform, it's just that like it's a flat rash. It's like in the measles.
Okay.
Yeah. Symmetrical rash on trunk and extremities. It does look like they've had slapped cheeks. Parvovirus is the culprit. It's non-infectious once the rash appears. And the incubation period 13 to 18 days. And just symptomatic treatment.
Jane says because hand, foot, and mouth will be caused by different viruses, you can get it again.
Different viruses of the Coxsackie family.
Yeah, she didn't say that, but she just said, yeah, because of the multiple viruses. So, yeah.
Okay, case 7. Well child, no fever, single lesion now spreading. And it's spreading often because of auto-inoculation. Doesn't bother the child, but really bothers the mother.
Yep, we've got molluscum coming up.
Yay, well done.
Yep.
Warty outgrowths, pearly, no inflammation, umbilicated. So it looks like an umbilicus.
Mexican hat. Mexican hat.
Mexican hat. That's the first time I've heard it called that.
Oh, yeah,
Molluscum contagiosum, pox virus. Yes, close contacts and auto-inoculation. Nothing. You can do more damage by using liquid nitrogen than just letting it go, because it doesn't, letting it go of its own accord, because it usually doesn't bother the child unless it becomes infected because they've scratched so much.
The less it bothers the child, the more it bothers
the mother. Yes.
Yeah, or the father. They get obsessed with it.
Case 8. There we go. Any ideas?
We've got measles there. Measles, 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 measles. Autism. Don't know how you got that, but
No.
Is it a typo?
Maybe. Okay, but what kind of measles? And what about you?
Not the regular measles, because they're not very sick.
Yes, well done, rubella.
Rubella, yes.
So
Chocolate
we call it German measles, and the Germans call it English measles.
Don't mention the war.
So it's a mild febrile illness, mild arthralgia. There are occipital glands, and the child didn't receive any childhood immunizations. And it's, of course, who are we going to protect? Oh dear. Who are we going to protect? Fine maculopapular rash, not unduly unwell, relevant to susceptible pregnant contacts. So that's why we're very keen that people are immunized. So
and it's a problem for pregnant women because of the congenital malformations.
Exactly.
It doesn't make the mother sick particularly, does it?
No.
No, it's congenital heart malformations, I think, are the common ones, aren't they?
Horrible they can have horrible malformations depending on when in the period of embryonic development that the measles, they caught the measles. Okay, 17-year-old schoolboy goes to the school ball. 1 month later, complaining of the sore throat, general malaise, glands in neck, rash over trunk.
Yep.
Query spleen palpable, and the photos come back from the developer.
Yep. No, well, everyone's got that one.
Oh, good.
Yep. Yep.
Yeah, the purpuric palate.
And you don't get glandular fever after the age of 30. You've had it by then.
And you've got, if you are going to, there's a differential around the sore throat, isn't there, Bruce? So with the sore throat, especially in our communities, you have to think about the differential being group A strep. And so if you are wanting to rule out, if you're wanting to rule out group A strep, or certainly if you're wanting to treat group A strep, you would, and you're thinking this age group, it might be this condition, you wouldn't be giving amoxicillin because of the risk of them getting that rash in 10% of cases. If it is infectious mononucleosis, which is glandular fever, you don't want to give amoxicillin because it will give them a rash.
If you were to give anything, you just give pure penicillin, but wait for the culture. If it's glandular fever, you'll get a virtual garden. You get all sorts of things, staph, yeast, anything but strep.
Yeah, unimmunized immigrant child, coryzal illness, then developed a cough, no respiratory problems in between bouts of coughing and vomiting with the cough. We got this? Yes. So it has a pathognomic cough, unmistakable when you hear it. Whooping cough. Highly infectious. Macrolides reduce the infectivity, so you could give the child macrolides. We are giving pregnant women pertussis immunization because the most affected individuals are those less than 6 weeks. They're the ones that die, end up in hospital and die with this condition, and you can't immunize them before 6 weeks. And the studies have demonstrated by immunizing pregnant women anytime after 16 weeks, although the most effective time is between 28 to 38 weeks, you protect the pregnant woman from getting pertussis, but you also protect the infant.
Karen, we're just about to time. Do you want to?
Oh, okay, sorry.
Any big take-home messages at this point?
No, just measles. The most important thing is if you've got an immunization for it, immunize. Measles is misery, and we've had a measles epidemic recently. Before the COVID-19, we had measles last winter, we had a measles epidemic in South Auckland. Very, very important to immunize. That would be my take-home message.
Okay, Karen. Well, so those of you who want to stay on and take more questions and answers, we'll leave you on. I'm stopping this now because I'm going to record it. We're recording it, and we will send you out a YouTube video of it, which you can pass on. It'll be made public, a YouTube video and the slide set in a PDF form. So just me to finally say thank you, Karen. I think that's been an absolutely brilliant session, and we're looking forward to you doing more work. We're going to get you into Red Whale and other such delicious educational events. So absolutely brilliant. Leave you with Karen. Okay.
Thanks, Bruce.